Hello again. It's so good to have you back for our final panel discussion of the day. Hope you've enjoyed the conference so far and gained a lot from it for your use, but also share with colleagues. The impact of artificial intelligence in digital healthcare has been transformative, revolutionizing the way healthcare is delivered, diagnosed, and managed. AI has already proven to be a powerful tool in enhancing medical practices, improving patient outcomes, and optimizing healthcare processes. One significant area where AI has made a substantial impact is in medical diagnostics. AI algorithms can analyze vast amounts of medical data, such as patient records, lab results, and medical images, with remarkable speed and accuracy. This capability has led to more precise and efficient diagnosis of diseases, including early detection of conditions like cancer. AI-powered diagnostic tools enable healthcare professionals to make informed decisions and provide personalized treatment plans for patients. I'm really looking forward to this panel as yet again we have a fantastic lineup of speakers. So do submit your questions on the right-hand side of the screen if once we get going you have some thoughts to put to our guests. And we have with us Mark Ratnaraja, Managing Director from our partner C2AI, Neelan Das, AI Lead and Radiologist at East Kent NHS Trust, Eleanor Provenzano, consultant histopathologist from Addenbrooke's Cambridge University Hospitals, Simon Mortimer, Assistant Director for Business Information for South Central Ambulance Service, NHS Foundation, and Anna Ribeiro, our AI Imaging Transformation Lead from the Royal Marsden NHS Foundation Trust. So looking up at the screen now, we have got a full house, which is great. Welcome to all of you. We'll kick off with Mark, if that's okay. Mark, I still think there's a lot of mystery surrounding AI. I just wondered if you could start off by giving us a broad idea of how it can really make a massive impact in healthcare before we dig a little deeper.
Speaking to everyone and sharing the stage with such a distinguished panel group of panelists. So when we talk about AI, actually we talk about AI with a small a being augmented intelligence rather than artificial intelligence. And the reason why I make that distinction is that a lot of work that we do is really around decision support and providing clinical and operational teams with an enhanced view of patient risk using existing data sets, but understanding at an individual patient level what their dynamic risk is and how that might change over time. So the example I would give is that we've been doing quite a lot of work as part of the elective recovery program. Everyone knows that the waiting list is getting longer, but actually it was getting longer well before the pandemic. And the challenge here is actually not just that the waiting times are getting longer, but actually it's a patient safety issue. Patients are getting sicker whilst waiting, either because of their underlying condition and or because of their pathophysiology, meaning they're more frail, they're more vulnerable to mobility issues, and of course their underlying condition as well. And so we use the artificial intelligence algorithms to use existing data sets, primary and secondary care, to track patients in terms of their specific risk as it pertains to their time and the type of treatment that they're having, but also importantly identify those patients who are at risk of decompensating. But all that information is really there to support the clinicians make a more informed decision about scheduling based on clinical need rather than trying to replace their clinical acumen.
And in turn, Mark, presumably helping reduce that elective backlog.
Absolutely. I mean, we all know that part of the challenge here is that there is a scarce number of resources, both in terms of physical resources, hospital beds, ICU beds, and so on, but also in terms of human capital as well. You know, there are lots of vacancies in hospitals that we're working in, as well as the issues around strikes and winter pressures and so on. And so being able to use those scarce resources more effectively, and indeed trying to find patients who would otherwise deteriorate and end up as an emergency, is an important part of getting that waiting list down. Because if you can free beds, reduce excess bed days, reduce the risk of avoidable harm and complications, and convert more patients into day cases by better understanding their patient risk, you can then better utilize that scarce resource and ultimately reduce the waiting list in a safer way.
Fantastic. Let's bring Anna into the conversation. Anna, you're at the Royal Marsden. What are the challenges for you of introducing AI into imaging research, and what are your hopes for the difference that it can make?
Yes, so obviously my context here is mainly, as you said, in research, so slightly different from the clinical implementation of AI. So I think there's a lot being said about some of the challenges of implementing AI in the clinic, but particularly in the close context of research, and especially in imaging, which is again a niche area. I think a lot of it depends on what type of AI technology and obviously what type of digital technology we're talking about. Is it a medical device or not? And depending on the classification of that medical device. And that leads me to one of the main challenges, which is regulatory approvals. So in the context of research, obviously there's we're governed by HRA and MHRA in the UK, and introducing AI into imaging research, it's not is not excluded from having a whole range of regulations, and actually navigating those regulations can be quite hard, both for developers and both for us in the clinics who want to implement and adopt them, starting with clinical investigations and then hopefully having the right evidence to support the clinical adoption. um, Alongside the regulations, I think data protection is also very important, patient security, and making sure that how we transfer data or how we share data with AI tool and vice versa is of crucial. Understanding what we need to have in place and how it interacts with the systems in each trust or each hospital. And leading to that, I think one of the other challenges that we frequently see when we're trying to adopt AI into the research is interoperability. So how does AI will interact with the clinical systems, and obviously in imaging packs as a crucial, but also is making sure that we are safe proofing that for when is ready to be clinically implemented, because actually sometimes within research it may be in a different environment, and because it's actually right to do so, so it doesn't impact on the clinical environment. But we have to think ahead, how will the technology then implement and work with the existing hospital technology. So I think those for me are still the main three challenges. So approvals, navigating the regulatory landscape, data protection, and making sure the interoperability is taken into account in terms of AI or any digital technology.
Yeah, they are big challenges to get our heads around, I'm sure. And Simon, you come at this from a slightly different angle, from the perspective of the ambulance service. What benefits can AI bring to the service, and what are you seeing already? Oh, hang on, we just need to sound up on Simon. Just try again, Simon. There we go.
I do feel like a bit of a rank amateur compared to my call, considering where they are in imaging. Two things. We come from an ambulance service, which it is very different from an acute or community setting. I've worked in both. And in terms of our AI, we're also coming from a slightly different angle, that we're using it for the business intelligence role. So it's management, decision-making support, clinical governance, rather than diagnostics and healthcare. We found it a very interesting journey. We're just about to go into production, if you like, on our AL machine learning platforms. We took a slightly different approach, but I'd like to say it was a grand strategy. It was more by accident, if I'm being brutally honest. That we've got very good relationships with universities at Hampton, and we got a lot of the students, and we identified some interesting business issues. Some of them were clinical, but some of them were staff, sickness, attrition. And as part of their work, we said, you've got to use ML AI type approaches to resolve this problem. So we kind of got a good benchmark of case studies, which we're now using with our suppliers, who we're just validating in the next few weeks to choose which solution we're going to use. It's a very different sort of thing with managing information, though, because it's a much broader context. You're not dealing with single type processes. There's so much more you've got to bring into it. And particularly with ambulances, where we cover a huge area and a huge population. It's very interesting, and the challenges are very different in terms of, we did some work looking at clinical demand profiling, what sort of things happen when. And I think in the end, we had to use 50 parameters to get a vaguely accurate model. Only about 20% of those were healthcare based. The rest of them were geospatial based, they were population, they were demographic based. So it was very interesting about how managing information with AI and ML is very much around, it's not Deep data is okay, but you need broad data. Our experience is you get a fall off very quickly with deep data. You need broad contextual data because we all know that health demand is not just driven by what's wrong with you. There's so many multiple factors. So we're still scratching our head quite a lot. I think my epiphany on it was I call myself a cynical advocate of it. I've worked in the software and software companies, and my epiphany was about 2 years ago, and how I sold it internally is this is just automated statistics. That's fundamentally what it is. So from a horrible NHS manager, I can be more efficient because I can get more out of my team faster, and the quality of what they do is going to be better. So that's how we sort of approached it. And we've got 4 or 5 case studies. We're taking those case studies and now going to productionize them as our first phase of, we're calling it the poke it with a stick phase. That's the sort of thing we do in the ambulance service. So I'm more than happy to say my knowledge of ignorance is virtually boundless. So we're in an approach now where we're trying to understand this, do the ML ops, do the ethics, do the governance. Does this really work? How do we do it? The cell stuff is great, but I want to be comfortable before we let this near anything which is clinically dangerous, that we understand it and we're in control of it. So that's sort of approach I'm taking.
We'll talk about regulation in a moment with you, but let's bring Eleanor into our conversation from Adam Brooks. Eleanor, what types of AI tools are currently there to assist in histological diagnosis, and what difference are you either seeing or hope that they're going to make for you?
I guess there are 2 main issues or 2 main areas where we're using AI. So one of the big problems in histopathology at the moment is staffing shortages that's leading to backlogs. And particularly in some sort of settings, it can be 2 or 3 months before biopsies are being reported because they're relatively low risk and they're being stuck in a backlog. And what AI tools can do is screen biopsies, highlight biopsies where there's a high risk of malignancy, and they can then be flagged and brought up the queue so that they're sort of prioritized and we can make a diagnosis of cancer faster. And I guess it also acts as a quality control step, because at the end of the day, it's like the augmented intelligence that Mark mentioned. It's going to be a pathologist still making the diagnosis, but the AI acts as secondary QC check, just to highlight the areas of concern to us and to make sure we're not missing anything. The other area where AI is going to be fantastic is in pathology, particularly in cancer. A lot of our job is assessing biomarkers. So that's counting the number of cells that are stained with a particular antibody and quantifying protein. And as people, we're actually very good at that at the very sort of fine end of the spectrum. So what AI will be able to do is refine that, make it much more quantifiable and reproducible, and identify particularly one of our markers is HER2 in breast cancer, and there's a new drug that can target very low levels of protein, and as pathologists we're not very reproducible at identifying that. So AI could be a real game changer in enhancing the reproducibility and therefore access of the drug to patients through detection of these biomarkers.
Fantastic. Neelan, I knew I'd get to you eventually. And AI in radiology, you're a radiologist. Tell us about the difference hopefully it's going to make or is making already.
Well, I'm coming from the point of view of, actual clinical deployment. So what we found in East Kent, we've deployed a chest X-ray algorithm, and I think it was the first one to be procured from the NHS SBS framework, which only came into being a couple of years ago. But I mean, I think I'd like to touch on what the other speakers have said so far. And actually the challenges when I first started the journey were immense, but actually I think it's getting a bit easier in certain areas of medicine and certain areas of AI to actually start deploying, what we call commercially mature suppliers who have perhaps done some of the due diligence, and you've got a benchmark of how they might perform, and then it's up to us to actually try and understand how they're performing in real life, and how what you call post-market surveillance, how that's actually going. So what is known as post-market surveillance in the European sort of medical device regulations is what we call audit. And for me, what we've seen so far, it's very early days. We finally deployed this algorithm in a live setting in the emergency department to analyze chest X-rays, really in June, and we've already seen that the speed of diagnoses that is available to an ED clinician, which ranges from a very junior doctor to an experienced nurse consultant practitioner to an A&E consultant. You've got a huge diversity of people looking at these films, and it's made a significant difference already in terms of picking up perhaps subtle pneumothoraces, nodules in the lung, which could easily have been missed, and have been picked up by our radiologists, the next day or even a few weeks later, because there's still a huge backlog on reporting these scans. We found that the sensitivity has stood up to what was touted and to what we did in our initial pilots, a couple of years ago. Obviously, COVID got in the way, and we updated our pilots. We were very cautious with our deployment. We're now in the phase where we're really garnering opinion for both qualitative and quantitative, garnering qualitative opinion through surveys and some meetings with our ED colleagues and radiology colleagues as to what they actually think of the software. ED has generally overwhelmingly been positive. The sensitivity rates are high, but the specificity rates are slightly lower. They're like overcalling junior radiologists, if you like, or overcalling clinicians. And that's what we want at the moment. We want these tools to pick things up and not miss things. But there will come a time, I think, where we'll get tired of all the slightly lower specificity, because what that actually means is great for the clinicians. What I call clinicians, the ED consultants, for example. But for the radiologists, they might now get constantly bugged to double check an AI film. And that may potentially, although it hasn't been borne out yet, because we've set strict guidelines that you're not to phone the radiologist all the time to double check an AI film, because that wasn't part of the bargain. But we may find that when, that a radiologist's role might start becoming double checking an AI. But actually, I think that we're in a transition period at the moment where we're doing real life deployments. Once they get better and better and we're more familiar with all these technologies actually on the ground, we're going to start working out ways to manage this new information, basically.
Yeah.
So it's the information management that's going to be key.
We've used the phrase exciting times a number of times in today's conference. I have, because it lights me up when I hear of real life, stories like you've just told there. I mean, Mark, obviously there's going to be challenges when implementing AI-based risk stratification tools. What challenges, are out there, and how are you overcoming those challenges? Or let's put your sound up, Mark, I think.
Sorry, can you hear me okay?
I know.
Yeah. The technology bit actually is relatively straightforward. As the old adage goes, culture eats strategy for breakfast. And unless you can bring people along with you, it doesn't matter how good the technology is, it's never going to get deployed. And when I say that, I mean everyone. So that's from clinicians making decisions based on AI tools and AI algorithms. That's operational staff that are implementing some of this for the benefit of the workforce and the patients, and making sure that there's strong leadership that supports all of this to happen. And of course, if you don't have any one of those three things, then it won't happen. And so we've been very cautious about collaborating and co-designing the sorts of implementations that we've been doing right from the outset. We started small, particularly post-pandemic. We were working with a number of trusts to really kind of get to the nub of what works and what doesn't work. And actually the feedback that we got from that, and actually the law of unintended consequences, things that we hadn't thought of that became use cases of how they then use these technologies, have just proliferated. And so by co-designing the work and making sure people are brought along with you, you get much more buy-in, and of course it's far easier to implement. And then the other benefit for us is that when we then talk to other regions where we haven't worked with before, there are people they can talk to, fellow clinicians, people in the same department, people who speak the same language as they do, people that they may know on the circuit, having met at conferences, that they can pick up the phone to and sort of say, how's it work for you? And all we're really trying to do is facilitate a lot of that.
Yeah, that's collaborations, but really, really important. Simon, I just wanted to talk about regulation. I mean, should we be aligning regulation with existing legislation and only developing new where it's really needed? What are your thoughts about the regulation around AI?
I mean, it's kind of at the forefront of my mind because I'm presently writing our ethical use policy, how we risk manage it and things like that. And it's obviously been in the news a lot recently with let's stop everything and throw it all in the bin to let's charge on. So I think my observation is we're in great danger of creating a regulatory framework and barriers which we don't really need to do. I come from a background where technology has to sell its way. And I think generally, if you start applying it into, we mentioned, the Data Protection Act 2018, corporate liability, corporate governance, confidentiality, data management rules, I think 90% of the challenges we have would be resolved by present legislation. It's about taking AI and ML use cases and taking them to that domain and sort of running them through. I speak to my IG lead, and she's quite calm and happy. She said, "It's data, you're processing data. The law doesn't change." I think the challenge is then about how do you risk stratify an AI model. Those separate things, which are very specific to AI/ML, are where we need to focus. But I think we're in a great danger of over creating a whole industry around the world and creating barriers which really don't need to be there. If you take this thing and put it into the rules and regulation that already exist, another thing we look at is we don't use neural net black box solutions because we can't understand them. We don't understand how it's got to an answer. Therefore, there's a whole lot of corporate governance, and in management information, you need to know the drivers because you need to know what's driving something. An example of that, we were doing some work around hospital queuing. You all know about ambulance queuing over the winter and the terrible problems that caused. And we had to say on that project, you can't use black box solutions because I was on call last night and I've had to ring my colleagues up at the hospital and go, I've got an 85% prediction you're going to have 20 ambulances queuing for 200 hours in an hour. They're going to go, why? And I go, I don't know. It's going to be a very short conversation, I can assure you. So I think we're in danger of getting overly hung up by regulation when we don't need to, is where I am. And we need to focus on those critical things about risk stratification and make sure we understand the consequences of these solutions and approaches to technology.
Really important. Anna, how do you see the imaging pathway being changed with the introduction of AI?
I think that's a very good question and a very hard question answer, I think. Coming from a research perspective, I think everything we do, some of the projects we're doing might be successful, others possibly won't be successful. That's the definition of research. One of the things that I think, obviously, enabling AI and digital technologies within imaging, I think, has been said: faster diagnosis, less waiting lists, supporting both the workforce and the patients. But I think one of the things that I think is crucial not to be lost is the human interaction. And obviously that has a broad spectrum and a broad definition. Human interaction may be a consultation via Teams, but it may also, be a face-to-face appointment. I think within imaging, a lot has been said on, and there's obviously has been said by Mark about, change. I think there is a big element of change, and we don't like change as humans. We like things to be the same way all the time, and we have to take everyone on board and all the opinions. So I think the change to the way the care will be delivered by the imaging is likely to change. I'm not sure how the new radiologist and how a new radiographer will work in the next 10 years, but I think it's the time to shape, and I think AI will change that. I don't think I have the answer to say how it will change, but I think it definitely will. A while back I listened to a talk, and I can't remember exactly by who, but he was saying, well, AI is a bit like electricity. It came, it was perceived as a dangerous technology by some, it was not regulated, and now it's part of our living world, and we can't imagine living without it. So I think it will shape and it will change the way in imaging, especially for the workforce, radiologists, radiographers, and across imaging, it will change definitely. And I think we have to embrace, and we have to take into account all the different opinions on what works for some professionals and what are the perceived challenges, I think. But
yeah, I think you're
just-
right. I'm sure it's going to get easier, isn't it, and more widely adopted as time goes by. I mean, my children are digital natives. I remember in my 30s being taught to send an email when the internet. I was like, "What's an email?" I use Royal Mail. So I suppose we're not at the beginning of it, but it's early days in our journey, isn't it? And the learning curve will be very steep, and hopefully the benefits really great. We've got a question for you, Eleanor, from Debbie. Debbie says, do you see NLP going hand in hand with AI from a reporting perspective?
Sorry, I missed the first part of that.
Do you see NLP going hand in hand with AI from a reporting perspective?
I'm not familiar with that acronym.
Yeah, that's okay. Debbie, perhaps because it says the question was for you. Maybe Debbie can put the acronym on. So we'll move on to something else, Eleanor. What about actually natural language processing? Does that make sense?
Yes, I must admit, from a pathology perspective, I'm more involved in image analysis and digital pathology. So I assume, I know part of the work we are doing is around developing AI systems to sort of extract information from reports and that sort of thing, particularly in the clinical trials context. But I guess in the area I'm involved with, the focus is more on the image side of things. So that's not something that I'm personally particularly engaged with. I'm sorry.
No, that's okay. Don't worry. And I was going to ask you how the implementation of AI in pathology can improve efficiency in patient care pathways. I'm guessing you're already seeing some of that happening.
Yeah, in one respect, we're a step behind our radiology colleagues. So I guess for them, the huge change has been that that's the primary format of the imaging now, is the computer-based imaging, as opposed to the old days when they had the films that they were putting up on the light boxes. Whereas for us, we still have to make the glass slides. Those slides still have to be scanned. So in some ways, it adds an extra step to the process. So the first thing for AI we need to overcome is the introduction of digital pathology. And there's been huge investment in that across the NHS. I know, speaking to some of my American colleagues, they're envious at the sort of the rate we're progressing in terms of introducing digital pathology. So that's the first step, is having the slides in that digital format that you can then apply the AI to. And I think that's when we're going to start seeing the real gains in terms of efficiency for patients. So it'll improve turnaround times by screening. So for example, what it could do is, at the moment, if I get a breast cancer slide, I have to review it, say that involves cancer, then I request extra tests. What the AI might be able to do is step in, screen the biopsy before I've even seen it, order all those extra tests. So when it comes time for me to do the reporting, I actually have all the information I need. So I think it's really going to improve efficiency in that way, and also sharing cases between pathologists. At the moment, we have to ship glass slides, and this will just be a much more efficient way to be able to sort of share expert opinions and improve care for patients.
Just briefly, Neil, and Claire says, have you found that AI has reduced or increased the workload for radiologists overall? She says, given the low specificity, or would this need to be extended to more imaging types before a significant change might be seen? And then I've got another question for you. So a brief one to that, if you don't mind.
So the low specificity is still around. The low specificity is still around 80%, but so far we haven't seen it increase the workload, but we haven't actually implemented it in a way where we would see that. The next phase is actually to make a normal and abnormal work lists for our radiologists. Someone's driving a F1 car past me there, I think. A whole load of integration to be done there. So I think we'll see. The jury's out. I think it's going to improve our workload, because when you create normal and abnormal work lists for specifically chest x-rays, you can ask your radiologist to target the abnormals first, and the normals can be, you do a 10% audit of that or something like that. And then we've got to go into legal areas about when can we actually start not reporting normal films. But that's to come. That's going to be a whole sort of national policy level area, I think.
Just a really brief one, Neelan, because I'm almost out of time, and I've got one quick question for Mark as well at the end. What, in your opinion, just briefly, what do we need to do to improve adoption?
We need to double down on the top 10 pathologies per year that affect the NHS and focus our money on them, is my opinion, and really go to town and try and bring AI in for that, to reduce the, you know, the volume based work that is here, and tackle that low hanging fruit. So, you know, I think that's what we need to do. We need to analyze that. There's so many AI technologies coming up, but we need to focus on a few areas and put that money into those providers of the software, the hospitals, and really understand the impact it has over the next 2 to 3 years, while still garnering other technologies to make sure we don't discourage them. And every 3 years, if we tackle those sort of 5 to 10 technologies, we'll slowly get through it.
Yeah, brilliant. Just a final thought, Mark, the role of population health and personalised health here.
Yeah, I mean, in my mind, there's a continuum between the two. We're starting to see that actually by understanding the risks of a patient at an individual level, you can then start to aggregate that up and then start to look at it at a population level as well. So part of the work we've been doing in Cheshire and Merseyside is to use these sorts of analytics to understand not only cohorts of patients undergoing elective surgery, but actually once you know what their risks are, then onboarding them onto chronic disease management pathways expressly for the purposes of making them fit enough to have their surgery. But actually that's a single touch point in a continuum of care that's probably going to be lifelong. So once you've understood what their risk factors are, their comorbidities, and you've started on that journey of actually onboarding them and making them participant in their own healthcare with the ambition to improve the outcomes for their surgery, it therefore means that they're then on that pathway to then improve healthcare and their comorbidities on an ongoing basis. And of course, if you connect that data between secondary care, primary care, you have a biopsychosocial view of the patient, then actually sharing that information and making sure that it's not siloed means that actually that then starts to inform things like population health. So some of the work we've been doing at an ICS level is really now starting to break down some of those local barriers and starting to think about things at a system level to say, actually, how can we move populations around to best serve the needs of those patients? It's not just about a patient going to an individual hospital, but actually where are the right resources, the right patient, right place, right time type methodology, and using the data to underpin that.
I knew the time was going to be against me because we've got 5 fantastic guests. It's such a massive topic. So I'm sorry I haven't spoken as much to Simon and Anna as perhaps I would have liked, but thank you all for being amazing guests. And I do hope that you'll join us again at one of these events because there's so much to talk about. We've hopefully scratched the surface there a bit. But thank you very much to Mark, Neelan, Eleanor, Simon and Anna for joining us on our final panel. Really exciting AI times ahead, I think. And a big thank you to everyone who's joined us for the conference today. I'd also, of course, like to thank our partners, as we really couldn't put on these events without their input, support and industry knowledge. And I'm looking forward to seeing many of you at our next event on NHS procurement. That's taking place on September the 21st. So please let colleagues know. I'm sure they'd be interested in being part of our community. A quick reminder, today's event was CPD certified with 1 CPD point earned for every hour of live content watched. Your CPD certificate should be with you within 24 hours. So from me and everyone here at NHE 365, thank you for giving us your time and attention. Have a great rest of your day, and I'll see you again soon.